We are live now.
Good evening, delegates and participants. Thank you for joining Shieldconnect. And today we have a special speaker from Assam, Dr. Priyanka Deb. Ma'am is going to take the topic vitamin D deficiency in pediatrics population. So let me introduce Dr. Priyanka Deb. Ma'am has done MD in pediatrics. Ma'am is specially trained in neonatology in Cincinnati Children's Hospital from USA. Ma'am has also done fellow observer in neonatology PGPN from Boston, Silchar, Assam. So we welcome Dr. Priyanka Deb ma'am on our platform for giving this information, knowledge sharing regarding vitamin D deficiency in pediatric population. So ma'am, we welcome you on our platform. Thank you, ma'am.
Thank you, Nishant. First of all, thank you, Shield, for giving me an opportunity to speak on such an important topic today. So should we start off with our slides? Today, I'll be speaking on vitamin D deficiency in pediatric population. We all now know that in today's era, vitamin D has become like water. So wherever we are drinking water, there is vitamin D also, which has been given. So, but it has been seen that there are many states in India which are deficient. So in the further slides, I would be speaking about how it has been deficient where and how we should tackle the situation.
Ma'am, sorry to interrupt you. Before going to the next slide, your video mode is not this visible.
Okay.
Just check that.
Yeah. Is it?
Yeah, now it's fine. Now it's fine.
Okay.
Yeah. Please continue, ma'am.
Yeah. So can I go into the next slide? Yeah. So what we know is that vitamin D is a fat-soluble vitamin. It is a pro-hormone which is synthesized in the skin after it gets exposed to the ultraviolet radiation or absorbed from food sources or supplements. So this pro-hormone is generally converted to metabolically active form in the liver and subsequently in the kidneys. So it is a fat-soluble vitamin, which is very important thing we should keep in mind. So this chart shows the states where the deficiency has been found. And now as I'm residing in Assam, I can see that Assam has deficiency of 23.4%, whereas insufficiency of 41.5%. So it's quite alarming, and I think we should work hard to improve this condition. Even Tamil Nadu is at a very high rate of 42.1 insufficiency, but deficiency is a little less, 14.3. Assam, Chhattisgarh, Maharashtra, and Punjab are the ones which are rising along with Gujarat. So two forms of vitamin D is there. One is the cholecalciferol and the other is the ergocholecalciferol. So we already know vitamin D3, which has been prescribed rampantly. That is a cholecalciferol. D2 is the ergocholecalciferol. So cholecalciferol is a vitamin D3 and it is found only in animal products and some vitamin D supplements. It is formed when this UV ultraviolet radiation wavelength of around 290 to 315 converts the 7-dehydrocholesterol in the epidermal keratocytes to the dermal fibroblasts, and then it gets converted to vitamin D3. It's a long process, so we just have to know that it is found mostly only in animal products. And ergocalciferol is D2. This is also found in plant sources only. So one is found in animal sources and the other is found in plant sources. And in most vitamin D supplementation, it is found when ergosterol in plants gets exposed to irradiation. So one is from our skin and the other is from the plants. What is 25-hydroxyvitamin D? This is the storage form of vitamin D. It is formed in the liver. After vitamin D, which has been produced in the skin or ingested, is bound to vitamin D binding protein, which I'll be speaking about in the next slide, transported to the liver, and it undergoes 25-hydroxylation to 25-hydroxyvitamin D, and this is the storage form. So calcitriol is the storage form of vitamin D. Now, what is calcitriol? Whenever we are speaking of D3 and further in future days, we will only be talking about calcitriol also. So what is calcitriol? Calcitriol is 125-hydroxyvitamin D, which is the active form. It is formed in the kidney. The storage form is formed in the liver and the active form is in the kidney. So that 25-hydroxy undergoes 1-alpha hydroxylation to 125 hydroxy vitamin D. This process is driven by the parathormone and other mediators, including hypophosphatemia, that is low phosphate levels, and growth hormone. Kidney production of calcitriol regulates the circulating levels of this active form of vitamin D. There are many sites for 1-alpha hydroxylation, including lymph nodes, placenta, colon, breast, osteoblasts, alveolar macrophages, activated macrophages, and keratinocytes. So this is a chart showing the pathways. As we can see up there, there's 7-dehydrocholesterol, which on UV lights in the skin comes to become vitamin D3. And then it goes to the liver, where it gets storage in the form of 25 hydroxy vitamin D. Then to the kidney, where it would be calcitriol, that is 125 hydroxy. 125 hydroxy increases the intestinal absorption of calcium, bone resorption, and decreases the renal excretion of calcium and phosphorus. On the other side, that is vitamin D2, that is the ergocholecalciferol. Even that same thing, it would go to the liver, form 25 hydroxy vitamin D, come to the kidney, and this becomes the inactive metabolite, 24 and 25 dihydroxy vitamin D, which is not required. So what are the sources of vitamin D? Cod liver oil. Frequently in this area, we have cod liver oil during the winter season that has high levels, around 1360 IU. Salmon cooked, that is a fish, which has 360 IU. Mackerel, 345. Sardines, which are found in tin fishes, have 270 IU. Milk, non-fat, reduced fat, whole, and vitamin D fortified have only 98 international units. Margarine has 60. Pudding, which is prepared with half with milk and vitamin D fortified milk, can have only 50. Dry cereals fortified with vitamin D can have around 40 to 50 international units. Liver beef, which has 30, and one whole egg has 25 international units. So I think we should always advise kids above 1 year of age to have one full boiled whole egg. So that can give them another addition of 25 international units. And those people who are non-vegetarians can be eating salmon and mackerel. That has the highest. Cod liver oil has a very bad smell, so many people don't like having it. We can go to the next. So exposure to sunlight, as we are staying in an area which has very good sun exposure, so we can go outside, which is an important source. Which season, latitude, and time of day is important. Time from morning 10 o'clock to 3 o'clock, exposure has been seen to give a wide range of vitamin D. So what is the function of vitamin D? As we've been speaking about how it comes, where it comes, how we get it. So what is the main important function? Important function is to maintain the normal blood levels of calcium and phosphorus. And why calcium phosphorus? Because it's required for our bones. So vitamin D aids in absorption of calcium. It helps in mineralization of bones, and it prevents rickets in children and osteomalacia in adults. Not only these few things to be added is that vitamin D prevents recurrent infections. Many studies have been seen that nowadays we are getting a lot of cases of wheeze, cough, cold. That can be prevented if vitamin D is given in an adequate amount. And even children on anticonvulsants, if they're given vitamin D, it has been seen that chances of convulsions have also come down. So the American Academy of Pediatrics, I will not talk about the National Academy as I don't know much about them. The AAP along with the IAP nowadays says any infant born from day 1 of life should be given 400 international units of vitamin D, whether the baby has been exclusively breastfed or not. So whether it is exclusively breastfed or formula fed, each infant should receive 400 international units of vitamin D from day 1 of life up to first birthday. Children 1 to 18 years should be given 600 international units if found deficient. So this is a picture of rickets. Nowadays, hardly we see these cases, but if there's high rates of vitamin D deficiency, they can have rickets and osteomalacia. What is ricket? Ricket in olden days, it means the turning, the twisting of the bones. So it means it's old English means ricken or twist, because of the bones have become so weak and there's so much deficiency of calcium and phosphorus that there is twisting, and it's also called as knock knee because both the knees come together. Apart from this, bending of the bones, widening of the wrist, bossing of the frontal bossing can also be seen, along with rickety rosary, that is the ribs. There'll be round bead-like appearance of the wrist. So these all are the extra findings. Apart from the skeletal, that is the lower limbs and the cervical spine, we can see widening of the wrist, frontal bossing, and they can be rickety rosary, that is bead-like appearance in the ribs. So associated, like I already said, infection, higher risk of upper respiratory infections have been seen with vitamin D deficiency, food allergies and asthma, childhood dental caries all obviously can be there, immunological conditions like multiple sclerosis, type 1 diabetes, rheumatoid arthritis, IBD, mood disorders, cardiovascular disease, hypertension, cancers such as breast, prostate, and colon cancer have been seen with vitamin deficiency. Excuse me. For dark skin pigments, because of the melanin function, it acts as a natural sunblock. So vitamin D production is affected. But in light skinned people, sufficient cutaneous vitamin D can be achieved by approximately 10 to 15 minutes of sun exposure to the arms, legs, hands, arms, and face between 10 to 3 o'clock during the spring, summer, and fall. But winter is good enough. You can sit in your courtyard or in a balcony and have a nice orange and enjoy the sunlight, and can increase the vitamin D levels. Exclusively breastfeeding. The vitamin D content of breast milk is very low. It's only 15 to 50 international units, even in vitamin D deficient, vitamin D sufficient mothers. So if the mother has been advised calcium and vitamin D also, it has been seen that breast milk has very low quantity. Although vitamin D deficiency is uncommon in formula fed, because nowadays all these formulas are fortified, but still we would advise, whether the baby has been formula fed or exclusively breastfed, vitamin D supplementation should be started. Obesity is also a risk factor because of sequestration of vitamin D in the fat. As it is a fat soluble vitamin, it gets sequestered there. So obesity is a risk factor. Decreased nutritional intake, like the primary natural dietary sources of vitamin D are all these oily fishes, cod liver oil, organ meats, egg yolk. So many people will not be having all this and they can have deficiency. If a child is on a medication like an anticonvulsant, sodium valproate, that can increase the catabolism of 25 hydroxy and 125 hydroxy vitamin D. They can decrease the vitamin D levels. Glucocorticoids, if a child is of nephrotic syndrome or is on oral corticosteroids, can have vitamin D deficiency, and those on ART, antiretroviral medications. Chronic liver and kidney disease can also lead to vitamin D deficiencies. Malabsorption conditions like celiac disease, IBD, chronic pancreatic insufficiencies like cystic fibrosis. So all these long-term diseases can cause vitamin D deficiency, and all these kids should be supplemented with vitamin D. So maternal vitamin deficiency is very important because vitamin D is transferred from the mother to the fetus across the placenta. So the reduced vitamin D stores in the mother can cause vitamin D deficiency in the infant. Even prematurity, we all know that premature children are already deficient in all the micronutrients, and so vitamin D deficiency has been found to be there in them. As already they get less time, they are delivered prematurely, less time is there to vitamin D to transfer from the mother, so they are also in vitamin D deficient conditions. So the vitamin D, how do we investigate? The vitamin D status should be determined by measuring the serum 25 hydroxy vitamin D. 25 hydroxy vitamin D has a half-life of 2 to 3 weeks. 125 has a shorter half-life, around 4 hours, circulating in much lower concentration than 25 hydroxy, and it is susceptible to fluctuations, including parathormone, in response to subtle changes. But I think in all cases, next slide, it is only vitamin D3 which is measured. So, but most commercial labs measure only D2 and D3, which is the derivative of 25 hydroxy, and the combined report will come. This is important because patients have different proportions of vitamin D2 and D3, depending on whether the source is cutaneous synthesis as D3, natural dietary D2, or fortified foods and supplements. So variability among assays remains an important problem. But this is the main problem which we are dealing, because whenever we get a vitamin D level, it is not mentioned whether it is D2 or D3. It is only vitamin D which is low. So that has to be kept in mind. Significant controversy has been associated with determining standards for vitamin D deficiency, insufficiency, and deficiency. Thresholds used to define these states are based upon the association of 25 hydroxy levels with clinical evidence of rickets, elevated alkaline phosphatase, and other bone turnover markers. So the levels are: sufficient is 20 to 100 nanograms, insufficient is 12 to 20, and less than 12 nanogram is vitamin D deficiency. So any child who comes with less than 12 is a deficient. Any child which comes in a range of 12 to 20 is insufficient, has vitamin D insufficiency, and 20 to 100 is normal, sufficient. Now, the additional evaluations which can be done is that possibility of rickets should be considered in a growing child with 25 hydroxy levels below 20. For these children, we should measure serum calcium, phosphorus, and alkaline phosphatase, and radiological evaluation should also be done, like an X-ray chest, X-ray wrist, and X-ray of lower limbs, hips, and spine. So vitamin D insufficiency or deficiency, how is the replacement done? So vitamin D replacement therapy is necessary for children presenting with low levels of 25 hydroxy vitamin D, less than 20, or rickets. The variety of response or dosing schemes have been seen. Either it is vitamin D2 ergocalciferol or vitamin D3, that is the cholecalciferol. So how do we calculate the dosage? Infants less than 1 year, it is 2000 international units daily for 6 to 12 weeks, followed by maintenance dose of 400. This is a case of less than 20, we have to keep in mind. Children more than 1 year, we have same thing, 2000 international units for 6 to 12 weeks, followed by maintenance dose of 600 to 1000 international units. So less than 1 year, it is 2000 for 12 weeks, and then come down to 400 for another year. This is in case of a child who has vitamin D levels less than 20. Children above 1 year will have 2000 for 6 to 12 weeks, then come down to 600 to 1000 for another 1 year. An alternative approach is 50,000 international units once a week for 6 weeks, usually given orally or IM. This is for a children more than 1 year of age. Although the total dose of vitamin D is higher for weekly regime, this approach has to be safe and effective in clinical trials. So this weekly shared thing is bound to be much more effective. We speak about the Strauss therapy also later. Okay. Children with established rickets need somewhat higher treatment. So those who have been found to be established with rickets less than 12 nanograms. So children more than 1 year through 12 years will have 3000 to 6000 IU. And more than 12 years will have 6,000 international units daily. This is given for 12 weeks with monitoring for efficiency and high risk for hypercalcemia, followed by maintenance dose. This is only in case of rickets. We go up to 3,000 to 6,000. The multiple dosing regimes have also been found to be effective. Like I was talking about the Strauss therapy, the cumulative amount of vitamin D supplementation appears to be more important. One study in adults found that the same cumulative dose given daily, that is the 1500 international units weekly or monthly, were resulted by similar. So what we use here is that if a child is found to be deficient, less than 20, we give 50,000 units weekly for 6 weeks, and then we shift to oral therapy. But less than 1 year, we cannot do that. So we continue with 2000 units for other 6 weeks and then come down to 400. So vitamin D can be administered as vitamin D2 or D3, like I already spoke about. The two forms are used interchangeably, particularly with daily dosing. The studies have indicated that vitamin D3 has a longer half-life than vitamin D2 and may be more potent, causing 2 to 3-fold greater storage of vitamin D. That is why vitamin D3 is given everywhere, which may be a better option because of a single large dose. We give a single dose, and it is stored for a longer period. That is why vitamin D3 is given everywhere nowadays. So the rare patient with severe symptomatic hypocalcemia due to vitamin D deficiency may benefit from an administration of calcitriol also, that is 125. In such situations, calcitriol administration at a dose of 20 to 100 nanogram per kg per day with IV calcium gluconate and higher doses of vitamin D may normalize the plasma calcium levels more rapidly than standard vitamin D treatments. So in those who require 125, we will use this. However, calcitriol plays no role in building up vitamin D stores and should not be used in patients with symptomatic hypocalcemia. Stores therapy. Short-term administration of vitamin D, that is a high dose of vitamin D, is an effective alternative therapy. It can be a good solution for patients who do not adhere to oral therapy. So straws should not be used for children less than 3 months of age, and careful dosing is important to avoid the risk of hypercalcemia. Here we give IM, dose 50,000 units IM, and then following every weekly once, and then shift to oral therapy. For patients with elevated levels of parathormone or clinical evidence of rickets, calcium should be supplemented along with vitamin D. Otherwise, what would happen? The hungry bone syndrome can occur because vitamin D replacement and normalization of PTH levels can precipitate hypocalcemia by suppressing the bone resorption and form increased bone mineralization, also known as the hungry bone. So whenever we're supplementing vitamin D, calcium should be supplemented along with it. To prevent hypocalcemia, calcium replacement is 30 to 75 mg per kg per day of elemental calcium in 2 or 3 divided doses. Calcium supplements should be continued for 2 or 4 weeks until vitamin D doses have been reduced to maintenance level of 600 to 1000 international units. Those 6 to 12 weeks when we are giving a higher dose, calcium should be continued together with that. And then when we come down to a lower dose, we can stop calcium. So how do we follow up? Patients presenting with only low levels of 25-hydroxy vitamin D and no other biochemical changes or evidence of rickets do not require intense monitoring. In practice, it is recommended to check 25-hydroxy vitamin D levels in such patients after 2 or 3 months of vitamin D supplementation therapy, then as needed thereafter, depending on the adequacy of patient's intake and adherence to maintaining supplements. It is generally recommended to check serum 25-hydroxy levels and other chemistries after 6 to 8 weeks of high dose therapy, then again after several months of maintenance therapy. So suppose we have given vitamin D, we give it for 6 to 8 weeks, check their levels after 8 weeks, and then we continue the maintenance therapy for a year and then check the levels after 1 year. So this is my last slide and it says thank you.
Thank you so much, ma'am, for giving the detailed information regarding this topic. And we are very pleased to have you on our platform for today's webinar. And we would like to have more sessions with you on this platform, Shieldconnect. Thank you so much, ma'am.
Thank you. Thank you for giving me an opportunity. Thank you, Mr. Deepak, Mr. Bharat, Nishant, everybody. Thank you.
Thank you. Thank you so much. It was really very nice and informative also, madam. So
thank you.
Have a nice evening, ma'am. Thank you.
Thank you. Same to you. Thank you.
Nishant, you got any queries, Nishant? Nishant, I think he...
Yes. So we can disconnect. Yes.
Oh, okay. Okay.
Okay.
Okay. Thank you. Thank you.
Thank you, ma'am.